Thank you, Dr. Apostolova. So, Indiana University School of Medicine began its health partnership with Kenya 30 years ago. Since then, the school's teamed up with Kenyans to bring life-saving HIV therapy to more than 200,000 people there, train more than 1,600 medical students, and establish 800 clinics across Western Kenya. Today, IU's work with Kenya, in partnership with the Kenyans and 13 other Western universities, includes cancer treatment, a maternity hospital, and involvement and growing income and food security. Dr. Adrian Gardner is the Stephanie and Craig Brader Scholar in Global Health in the Department of Medicine, Division of Infectious Diseases. He served as the Executive Field Director for the AMPATH Consortium, which stands for the Academic Model Providing Access to Healthcare, based in Eldoret, Kenya for the last 7 years, and has been affiliated with the Kenya program since participating in a clinic rotation there in 2001. He received his undergraduate training and medical degree from Brown University, and then completed his residency in internal medicine and fellowship in infectious diseases at Harvard Beth Israel Deaconess Medical Center. He also has a master's in public health that he earned at Harvard University. His talk this evening is Transforming Lives Through Global Engagement. Please join me in welcoming Dr. Adrian Gardner.
Good evening, everyone, and thank you all for being here. I'd like to start by telling you a story about Bramwell. I met Bramwell in February of this year when he was admitted to the medical wards at Moi Teaching and Referral Hospital in Eldoret, Kenya. Bramwell is 25 years old, and he lives about 150 kilometers west of Eldoret. He lives with his father and several other relatives in a home that has mud walls and a tin roof. Bramwell is unemployed. He finished high school, but he's unable to find a steady job over the last few years because the unemployment rate in his region is over 50%. In November of last year, Bramwell began to feel unwell. He started to have fevers, night sweats. At first, he didn't seek any care because he was concerned. He didn't have health insurance, was concerned about the cost. But by late January, he began to feel worse. Difficulty in swallowing, cough, and he lost a lot of weight. A friend had told his father that maybe he should be taken to Eldoret where some doctors working with AMPATH might be able to help him. So he took him, and when he arrived at the clinic, he waited for 4 hours in line before he could be seen and evaluated. And by the time he was at the front of the line, he basically just had to be admitted to the hospital. I was Bramwell's attending physician that day on the wards, and I remember our initial assessment. Bramwell had tumors in his mouth, and tumors on his skin. And I started to tell Bramwell's father that he needed to raise some funds for a chest x-ray and a biopsy. Because you see, in Kenya, if you don't have health insurance, you actually have to pay for the tests that you need up front. Over the next few days, Bramwell got some bad news. His blood test was positive for HIV/AIDS. His chest x-ray and sputum results showed that he had pulmonary tuberculosis. And his skin biopsy showed that he had, an HIV-associated cancer, a Kaposi sarcoma. But despite all that, remarkably, he did pretty well. He got started on HIV medications, started on anti-TB medications, got a blood transfusion, and was actually discharged after a couple of weeks. Now, let me just be clear. If Bramwell's father had not had the resources and the wherewithal to bring Bramwell to the hospital in Eldoret, where Indiana University has partnered with Moi University for the last 30 years to build the specialty capacity, Bramwell would be dead. Instead, because of the AMPATH partnership, this is what Bramwell looks like 8 months later. 50 pounds heavier, cured of his tuberculosis, having completed 6 cycles of chemotherapy for his cancer, and with an HIV viral load that's completely suppressed. And there are many stories like this. This is Eunice. She was hospitalized for so long that she lost her job, but she was employed in the fair trade organization that AMPATH created. And slowly but surely, she pulled herself out of poverty, regained her health, and regained her dignity. So these are some of the beneficiaries of AMPATH's work. So what is AMPATH? AMPATH stands for the Academic Model Providing Access to Healthcare. And it's the name of a partnership between Moi University, Moi Teaching and Referral Hospital, which is a hospital in Western Kenya that serves about 20 million people, and a group of North American institutions that you can see listed here that have agreed to work under the leadership of Indiana University. The 30-year partnership is one of the most successful global health partnerships in the world. The partnership is built on the principle of leading with care and the belief that academic health centers have an innate ability to serve the community around them and improve their lives. For 30 years, Indiana University faculty have worked alongside Kenyan faculty, delivering care in the hospital to patients, building innovative systems for delivering care in the communities, teaching medical students and residents, both Kenyan and North Americans, and engaged in cutting-edge global health research. There are literally so many dimensions to this partnership that it would take me all night to explain all of them. Thankfully for you, I'm not going to do that. But let me give you a few highlights, at least so you understand the depth and the impact of this partnership, because it really is something that all Hoosiers should be proud of. I first encountered this program as a medical student in 2001, and the experience clearly had a profound impact on my life and career. But I'm not alone. Over 2,000 North American medical students and residents have participated in the medical exchange program, and many of them describe this as eye-opening, life-changing, transformative. Over 400 Kenyan medical students have come the other way and engaged in the North American health system because we believe strongly that medical exchange should be bilateral. In 2001, the HIV/AIDS epidemic was ravaging communities in Western Kenya, and in response, AMPATH started an HIV treatment program, initially using private philanthropy. It was very clear from the beginning that HIV medications alone were not going to be enough. As Joe Manlin likes to say, there were three heads to the monster we were fighting: poverty, hunger, and disease. So we had to have a strategy that was holistic and empowered the community economically to overcome the barriers to care, and we had to take the battle to the community, not wait for people who were sick enough to come to the hospital. With support from the President's Emergency Plan for AIDS Relief, which was launched by the US government in 2004, we went door-to-door testing for HIV. And now the AMPATH Ministry of Health program supports 160,000 HIV patients at more than 800 facilities in Western Kenya. Now, the rapid scale-up required us to build an electronic medical record system, and faculty at Regan Street Institute built an open-source platform called the OpenMRS, now used by implementers in over 80 countries throughout the world. The longitudinal data collected by AMPATH has served as a foundation for research that informs policy and care systems throughout sub-Saharan Africa and the world. In total, AMPATH has attracted over $140 million worth of research funding and has produced over 600 publications. Now, AMPATH has gone on to develop new models of care delivery for maternal child health, high blood pressure, diabetes, mental illness, all in response to the needs that we see in this community. And for the last few years, our efforts have been focused on a holistic model of population health, inclusive of programs to address economic empowerment, improve care for acute and chronic diseases across the spectrum of the health system, all the way from the household level all the way to the national referral hospital, and models of sustainable health financing. AMPATH is poised to demonstrate a much-needed model of sustainability, just as the government support through PEPFAR declines. This model, in fact, has been so effective that we're now replicating it within the AMPATH consortium. So stay tuned, you'll soon be hearing about AMPATH Ghana and AMPATH Mexico. So I'd like to end this evening with another story, a story about Mary and Stephen. Mary and Stephen are a couple who, similar to Brahma, also live in a rural area with insufficient access to medical care, and they have no medical insurance. They showed up at a free health camp set up in a community church with a referral note that read, "Urgent needs from head to toe." By the time they arrived, they were 462nd in line for the camp and had to wait 5 hours before they were seen. Now, it turns out that Mary had several chronic medical conditions: chronic pain from peripheral neuropathy, digestive disorder, and severe anxiety and depression that manifested with panic attacks. Mary and Stephen had also lost their jobs and were actually intermittently homeless over the previous years. By the time Mary was evaluated by the nurse, she had severe muscle aches, and she, similar to Brahma, had to be taken to the hospital and given IV fluids and potassium supplements. But when she was released from the emergency room, she didn't go directly home. She returned to the health camp because she knew that there was no other way of getting a mammogram that she otherwise wouldn't be able to afford. Some of you may actually recognize this story because it's not actually from Western Kenya. It's actually from a story from a couple that lives 5 hours south of here in rural Tennessee. and their story was documented in the Washington Post a few months ago. My point in sharing it is to make the point that there are many people in the United States who face challenges with our health system that are very similar to those that we see in Kenya. And there are enormous opportunities to learn from the models we've developed in places like Kenya, where the lack of resources force us to be creative. There's no doubt in my mind that some of these models can help us here in our own backyard. So I'd like to close with this quote: "Global health is as local as it is international. It should be viewed, I argue, as a philosophy based on the values and expectations found within ourselves and our communities. Responding to globalization lies not only in knowledge, but embraces human rights, justice, and more importantly, self-awareness. Knowledge is more easily translated into curriculum objectives. We risk letting future clinicians and their patients down if we ignore the other universal values." These are some of the values that our students and faculty have reaffirmed during their rotations to Kenya, but they're just as applicable here in the United States. Thank you all for your time and for your support. As we say in Swahili, asante sana.